But it's a real pleasure for me to come back and see Bernadette after all these years and hear about how some of our classmates are doing and what they're up to. My malaria journey actually started here in New York about 60 blocks north here when I was a medical student at Cornell. And I initially thought I might go into psychiatry, but got kind of diverted into parasitology and ended up having a life-transforming experience in Indonesia, studying typhoid fever and malaria. And the young man on the front of that motorcycle there is now the in-house counsel for the world's only company that works on developing, exclusively on developing malaria vaccines. That's Alexander Hoffman, whose dad, Steve Hoffman, some of you may know, my early mentor. And when I got into doing malaria research in the early 1990s, this was the statistic that we would put up when we were introducing the topic, that upwards of 5,000 children were dying from malaria every day. Now that number would be about 1,000 people. So it's still a tragic number, but it's about an 80-fold reduction in the number of malaria deaths, and that kind of progress is what's led us to think about elimination and eradication. So just a quick snapshot of malaria. As you know, it's a parasite. It's transmitted by the bites of the female Anopheles mosquitoes. The numbers now are upwards of 200 million cases of clinical disease. So, of course, many more people infected, but a number of cases of clinical disease every year, and something around 400,000 or 500,000 deaths, down from more than 2 million deaths 25 years ago. The vast majority of those are in sub-Saharan Africa, and most of those in that setting are in the relatively non-immune infants and children, and then, of course, pregnant women who lack placental immunity in their early pregnancies. And global eradication is our goal. So just by way of definitions, when we talk about malaria control, we mean reducing the incidence of the disease so that it's no longer a major public health burden. Elimination refers to interrupting transmission and getting rid of the disease in a given geographical area. So we would say we eliminated malaria from the United States, from Italy. We're trying to do that now in other countries. So it's typically a country or a region. Eradication is when there's no more transmission anywhere in the world. And finally, extinction is, of course, when there's no pathogens on the planet at all, even in the freezer. So I'll kind of toggle back and forth between talking about elimination and eradication. So, of course, we know that malaria can be eliminated. This was the distribution of malaria in the United States in the 1800s, all the way up through New England and into Canada. And then by the 1930s, it had been pushed back to the southeast of the United States. And then much more patchy distribution. Sorry, that was 1912, 1930s in that slide. But the vector population, the Anopheles mosquitoes, were present throughout much of the continental United States, barring the kind of the Rocky Mountain and the parts in the middle of the country. The vector was everywhere. And initial attempts to control and ultimately eradicate malaria were based really on two interventions. Insecticides, primarily DDT in early days, starting in the 1950s. Indoor residual spraying the insides of homes to prevent people from being bitten by malaria-infected mosquitoes, as well as drugs, which I'll come to, anti-malarial treatments. And based on the availability of these very effective, inexpensive, well-tolerated interventions, there was a great deal of optimism that we had the tools in hand that we could truly eradicate malaria from the globe. The exuberant optimism was such that there were schemes to put chloroquine, the anti-malarial drug, in the salt supply. So every time you put salt on your eggs in the morning, you'd be taking some anti-malarial drugs. And as you can imagine, that ultimately resulted in the appearance of chloroquine-resistant malaria, initially on the Thai-Cambodian border, spreading through Asia, and then eventually to Africa, where it caused really catastrophic increases in malaria deaths and hospital admissions that had been greatly reduced by the availability of good drugs to treat malaria. And that eradication campaign is kind of typically described as a failure. And I'd like to challenge that a little bit, and just bear with me as we look at these maps. So these are maps of the world distribution of malaria in the 100 years before eradication effort. I can't quite see it. I think this is the mid-1800s, and this is 1945, so just a few years before the eradication effort started in the late 50s. And you look at these two maps, there's virtually no difference, right? Until we had good tools, interventions, the parasites were present very widely around the world. During the eradication era, from 1945 to 1977, you see how dramatically the map shrunk. So that eradication campaign failed to eradicate malaria, but malaria was eliminated in many countries and regions, and many millions of lives were saved. So in that sense, it certainly was a successful endeavor. And then when the eradication campaign kind of came to a halt in the late 60s and early 70s, the attention shifted from thinking about malaria as an infection that's transmitted and the kind of the biology and epidemiology as a pathogen and focus on the mosquito, to more thinking about it as a clinical disease. So the goal shifted from interrupting transmission more to preventing severe disease and death. And with that shift in focus, this is what you see. Basically, the map doesn't change again for the next several decades. And so with this history, why are we now talking about eradication again? Well, one aspect is there's been a lot of enthusiastic advocacy, resulting in movie stars like George Clooney answering your questions on malaria in the New York Times. People like Bono and Madonna are out advocating for bed nets. That has a real impact on our political system. The U.S. government has contributed massively to malaria control and more recently elimination through their contributions to the World Bank, to the Global Fund to fight AIDS, TB, and malaria. More recently, the U.S. President's Malaria Initiative. So in all these different aspects, the major contributor has been the U.S., and you see this dramatic increase in the early 2000s in funding for malaria control and then subsequently elimination. And that has had a real impact. Even in some of the toughest places, including in sub-Saharan Africa, you see dramatic declines in places like Zambia, Rwanda, where the burden was really high, where the public health infrastructure is limited, where there are a lot of challenges, and nevertheless we see some really impressive progress. Mainly the tools have been the long-lasting insecticide-impregnated nets that prevent people from being bitten when they're sleeping from indoor nighttime biting mosquitoes, indoor residual spraying, mainly these days with much later generation insecticides, and then artemisinin-based combination therapy, very effective drug treatments based on the artemisinins, initially an ancient Chinese herbal remedy used for at least 2,000 years to treat fevers in China before it became a medicinal compound used in combination to try to prevent the emergence of resistance. And there are other interventions such as mass drug administration, treating the whole population in an area where there's a fair amount of malaria without trying to test individuals and treat only the infected ones. And then potentially vaccines. But these are kind of in italics here because they're not widely deployed at this point. They're still mainly being evaluated. I think we have to give credit to George W. Bush, who not only started the President's Malaria Initiative, but the President's Emergency Program for AIDS Relief, PEPFAR. They've now distributed more than 300 million insecticide-treated nets, which not only knock down malaria cases, but actually have a very measurable effect on overall childhood mortality in places where malaria is a major problem. And so based on these successes, on the declining burden of malaria, our malaria community was shocked in 2007 when Bill and Melinda Gates convened a meeting and issued a call for global malaria eradication. It was based in part on a rationale of we have the tools, we've seen great progress, we need to apply them and continue to do research, and it's within reach potentially. But really the argument that Melinda Gates made was that it's a social justice argument. We used to have malaria in the US, in Europe. Our kids are no longer dying of malaria. It's simply not just, it's not fair to allow children to die of malaria in sub-Saharan Africa, India, in Southeast Asia, and other parts of the world. And we continue to make progress. This is a kind of a dynamic map you can get at a website hosted by UCSF. The countries in green have eliminated malaria. They've been malaria-free for at least 3 years and certified malaria-free by the WHO. In the kind of dark pink, there are countries that are actively eliminating malaria. And actually, this map is incomplete because I see the Myanmar and some of the other greater Mekong subregion countries actually should be the darker pink. They're targeting elimination now. They're committed to it. And then the lighter pink are still kind of in the control phase. But note that the distribution of malaria is very heterogeneous. Nigeria alone accounts for 25% of the clinical malaria cases in the world. And then you see the other kind of leading countries there, including India, notably, where we'll be hearing, I think, a little bit about some of the malaria work there in the next session. But my experience as somebody who goes out into the field, I worked for many years, as Bernadette mentioned, in sub-Saharan Africa, where the burden is very high. When I wrote grants about our work in Myanmar, until recently, I would say that Myanmar has more malaria than all the other greater Mekong sub-region countries combined: Laos, Thailand, Vietnam, Cambodia, and China's Yunnan province. That's no longer true. It's actually hard to find cases of clinical malaria in rural Myanmar and gold mining and plantation areas where we're doing our work now. And we've actually resorted to very highly sensitive, ultra-sensitive PCR methods to find even anybody who's infected. So we're going into places that until just a few years ago had a fairly high numbers of cases of clinical malaria. And we're finding single digits to maybe teens, and in some cases 20% people infected with very low density infections with Plasmodium falciparum and vivax. And so the focus of some of our research is trying to understand how important are these asymptomatic infections. We didn't have these super sensitive methods when we eliminated malaria from Italy, the US, former Soviet Union, and because there's been a lot of push from the Global Fund, Gates Foundation, and others to go after these with mass drug administration. So some of our work is trying to understand really what are the best tools and approaches to accelerate this goal of elimination. And the picture here on the right is from the Department of Medical Research lab in Yangon, Myanmar, where we support a high throughput pipeline of this molecular surveillance that has supported both our research but also national malaria surveys, and has now done something like 50,000 of these PCR-based tests using dried blood spots that you can see. And surveillance is indeed a very critical part of malaria elimination. So just one example of the kind of work that we're doing aiming at elimination is that we supported the Ministry of Health and an NGO called CPI in Planetary region, the kind of long spit of Myanmar that borders Thailand, evaluating villages for potential targeting with mass drug administration. And of 35 villages we surveyed, 50 people in each village, only 2 people tested positive by the standard rapid diagnostic test. So based on the standard testing, we say, well, there's hardly any malaria, we can move on. But we found prevalences of falciparum and vivax malaria of up to 20%, and the villages with the higher prevalences were then subjected to 3 rounds of mass drug administration. But this is unpublished. Basically what we found was that you can accelerate elimination by a year or so, but just by scaling up the basics, training community health workers to do diagnosis and treatment, you still get to the same very low levels approaching elimination. And I think that's an important lesson. So eradication is the goal. We're making progress. What are the threats to that goal? Well, the classic ones that we are all familiar with are mosquitoes becoming resistant to the insecticides, the parasites becoming resistant to the drugs. But of course, it's a complex ecosystem in which malaria thrives. So simply poverty, conflict, war zones. In Myanmar, there are 17 armed ethnic militias ringing the country, and until recently, all of those were in active armed conflict with the central government. So in those areas where the Ministry of Health can't get to, there are kind of different levels of coverage of basic health needs by the ethnic health organizations, but it's a complex, challenging situation, and that's where eradication elimination is going to be the hardest, where the health infrastructure, the health systems are weak. That's going to be the real challenge. And this is a long-term goal. Actually, I've had one conversation ever in my life with Bill Gates, and the question I asked him was, what about donor fatigue? You know, he actually said at the tropical medicine meeting where he spoke that he does hope and expect to see malaria eradicated in his lifetime. Of course, I wondered if he knows something about life extension technology that the rest of us don't know yet. But he had a very thoughtful reply that the people who are in this, at least at the kind of expert level and the thought leaders at WHO and Global Fund and so forth, realize this is a long game. But I'm not sure that our politicians who fund the work understand that, and that's a theme that I'll come back to. But the topic for this meeting today is really on climate change. And I'll tell you what I've learned about that as I've tried to look into this. So I think the first point to make is that whenever anybody talks about climate change and disease, malaria is kind of at the top of the list, as it is here from the slide from CDC that my friend Michelle Berry kindly shared with me, of diseases that would be affected. And it makes sense, right? Malaria is transmitted by mosquitoes, which is very, vectors are very subject to changes in climate and environment. And this has gotten a lot of public attention. There have been a few bursts of alarm in the press, especially in UK for whatever reason, that climate change is going to bring new risks for malaria and other vector-borne diseases to the northern countries. And it does make sense, right? The climate factors affect both the biology and the life cycle of the mosquito itself, but also impact on the development, the sporogony of the parasite in the mosquito. So it's logical. And moreover, the efficiency and the intensity of malaria transmission impact not just how many people are at risk of being exposed to mosquitoes that could give them malaria, but also impacts on the severity of the disease. And because people who are repeatedly exposed to malaria eventually develop immunity, and so you can see these different curves, the highest transmission at the top. In higher transmission settings, there's a lot of severe disease and pathology in younger kids in much higher numbers. And then in more stable conditions, if you look across age on the x-axis there's kind of a flat distribution. You see severe disease in older people. So you might surmise that as you control and eliminate malaria, the risk of severe disease will move up into upper ages. And indeed, that is what we see in highlands. This is from studies from Tanzania, so looking at the x-axis here in older age groups, and in the series moving from left to right or higher altitudes in the highlands. So as you move up in altitude, you see more severe disease in older people, although a lower incidence overall of disease. And it makes sense to think about climate factors changing that calculus of how high in altitude will you see malaria and will you see different age distributions. And so there's been this kind of debate in the literature about to what extent climate variability accounts for outbreaks in the highlands. Not being a modeler, I've looked through the literature, and there's been kind of a back and forth about whether it's climate variability or other factors. And indeed, there's some publications that look at a variety of models. In the top panel there, these are observed distributions of malaria in different time periods, and the results of models, some of which look to kind of replicate the actual observations for the 2000s fairly accurately, but others of which are very different, right? So there's large uncertainties in modeling approaches to predicting the impact of climate change on malaria. But if you read the fine print, this particular debate, where there was sort of one group of authors debunking another set of work done by a group, the point they make is not that climate change isn't impacting malaria. It's that it's the increase in temperature and not the variability. So it's really not so much a matter of whether, but how climate impacts on malaria. So you see statements like this that we shouldn't obsessively think about climate change and malaria, that it's very complex, that principal determinants are linked to ecological and societal changes, politics and economics, and that's certainly all true. It's a very complex picture, but climate is clearly important. So what about the risks to, as temperatures rise to, the map extending back up north? This is something that's been very prominent in the popular media. Well, even as far back as the late 1700s, Benjamin Rush was talking about the risks for malaria and approaches to combat it 100 years before we knew that malaria is transmitted by mosquitoes. And there were very clear associations between people living near mill ponds. The primary source of power for manufacturing was water power in those days, and so there would be dams and mill ponds. People would get fevers, and actually, when that was the dominant form of power for industry, there were laws passed that people living near mill ponds could not sue the mill pond owners, and that legislation only disappeared after the power source shifted from water to coal and steam. That was really well understood. And again, I'm reminded that 100 years ago, the distribution of Anopheles vectors was throughout much of the United States. I think that's Anopheles quadrimaculatus over there on the left. And in fact, this is from Finland from the 1940s. These are hundreds of cases of malaria in Finnish soldiers contracted in Finland. So malaria was present all throughout the temperate world, up as far as Canada and Scandinavia. And well, that's the that's the map of the malaria vectors 100 years ago, and these are based on both simulations and collected data on the prevalence of different Anopheles vectors contemporarily. So the mosquitoes are still here, as they are in Europe and England and elsewhere. And so while we're at great risk of resurgences if we back off on malaria control in the areas where malaria has been highly prevalent, and you see when you stop control efforts in all these different countries, what happens with rates of malaria. The real risk is in the settings where the health systems are weak, where the burden is high, and where we haven't reached elimination. Elimination tends to be very sticky, if you will. Once you get to zero, it's actually not that easy to reintroduce malaria into a setting, even though the vector remains there. And so one of my main points is that the malaria ecology and biology, epidemiology are very complex. And so the impact of climate change on malaria and on malaria eradication is not strictly going to be climate variability and increasing temperatures that favor expanding the range of the mosquitoes. It's going to be catastrophic weather events like cyclones in Bangladesh here, and especially movement of people, where you have the competent vectors present and the parasites are gone from the population, an influx of infected people in a setting where you don't have the infrastructure for good surveillance and prompt outbreak investigations, availability of diagnosis and treatment. That's, I think, the real risk. These very complex situations. And so some of my take-home messages are that climate change is affecting and will affect malaria incidence, malaria prevalence, and malaria distribution. And there's much uncertainty about exactly where and how, but really not about whether this impact will occur on malaria eradication. The impact is going to be greatest in the most vulnerable people and places. We eliminated malaria from the US and Europe and other countries. We didn't eliminate the mosquitoes. So the vectors are already here, so warming won't bring the vectors to Maryland, North Carolina, New York, and they're already here. And so the risk of reintroduction is quite limited where health systems remain strong. There are occasionally small outbreaks when travelers come in, but where you have a perfect storm of in-migration of infected people with a health system breakdown, I think that's where the real risk is. And so we need nuanced interdisciplinary approaches of the sort that this community here at this school is known to take. And we also need effective advocacy and clear messaging. The sort of academic debates about is it variability, is it increasing temperature, can be interpreted by people in Congress and policymakers as, well, we just don't know. And I think we have to be careful to have nuanced debates in the scientific community but clear messaging in the advocacy and policy realm. And so this kind of approach that you're discussing in this symposium today of planetary health, where we really look across all aspects of factors, including social and political and economic factors that affect health, that has got to be the way we go. And we as scientists have to get outside of our comfort zones and partner with people like think tanks in DC, the Center for Strategic and International Studies, that we've worked with to prepare documents for Congress and hold events, writing op-ed pieces. This is from the LA Times on our work in Myanmar, where we gathered together people from across the political spectrum and got them to talk to each other, people from the Myanmar military, the Ministry of Health at the time that the military party was still ruling the country, members of parliament from Aung San Suu Kyi's opposition party, and even members of ethnic health organizations that were still in active armed conflict with the government. Partnering with CSIS in DC, we brokered an event that actually set up new relationships and established trust among these groups that had very adversarial histories, culminating with a press conference where they agreed and declared publicly that they were going to work together on malaria elimination and partner irrespective of the outcomes of upcoming elections and without waiting for ceasefires to be negotiated. So I think this kind of approach that you take here at this school of not just kind of limiting ourselves to the health and the biomedical science is absolutely what's going to be required for elimination and eradication. So this is my wife and colleague Miang Nyunt, whom I should credit for our work in Myanmar. We've gone back to CSIS and continue to get outside of our comfort zones in the interest of having an actual impact from our work on malaria. And with that, I'll thank you for your attention.